I'll never forget it. She asked me, she's like, and remember, she was fresh out of PA school. She had only been with me, I think, a couple months or something like that. So she's a newbie. So she asked me, what's going on? I said, I don't know. They said like some penis got cut off. It's in the trash can. And the look on her face was just priceless. She was like, what? And I said, I know. I said, I know. I said, let's just go back and let's see what's going on. So I went back into the OR, and I kid you not.
We gon' do it like priceless. Take it to the moon. Priceless. One day will be soon. What is price?
Happy Tuesday, everybody. Welcome to another episode of D-Talk with Dr. Pham. We got some interesting topics today, but I have to put out the disclaimer first. This is really my advice and my thoughts and what I would do. This does not take the place of a healthcare professional. So please don't self-diagnose and self-treat. It'd probably be hard for you to operate on yourself and make your penis longer, but you get the gist. Because we talk more, not just about penile reconstruction, which is what I kind of specialize in, but we talk about everything. And then number two, the most important thing, click the subscribe button. That'll let us know that, you enjoy this video. I do this as a public service just because urology is not really a field that everyone really knows about, like diabetes or hypertension, where everybody knows about it. People don't know buried penis or, kidney cancer and stuff like that. And so kidney stone, stuff like that. And so my goal here is really to kind of educate the public on the general urologic pathology and symptoms. And then from there, seek professional care. And then obviously, like I said, subscribe to and watch so that it'll let me continue to do this. And I want to give a big shout out to Focus, Focus. They're the one who produces the show, and they've been doing an amazing job in just 6 months. We've reached millions of views, and it's just amazing. And all this just started because I just am a big believer in knowledge is power, and I do this really as a public service. So today we're going to talk about a topic that a patient specifically wanted to watch before his surgery, but unfortunately, I just have such a huge surgical backlog that, it's just hard for me to run out here and try to do the podcast and then try to operate on patients and try to build out our new clinic. And it's a lot of work, and running 4 different companies is not easy, I can tell you that. And so I don't even know how I do it, to be honest with you. But so unfortunately he wasn't able to see this episode before the surgery, but the good news is the surgery went well. He's doing fine, and he's cured, and that's what's most important. So what he wants me to talk about was urethral disruption or urethral transection. And so what I mean by that is the penis, I'm no Monet, okay? So just bear with me. But the penis has a general shape kind of like that. And then you kind of have your bladder kind of sitting up here like that. And then your kidneys are up here. And then, as you've seen on my multiple episodes about how the urinary system works. And so the urethra in guys spans kind of below the two cylinder or corpora. And just a little refresh on anatomy, and this is the scrotum. And this is kind of the top pubic area, or kind of the suprapubic area, which is separate from, the fat that you see on the belly, what we refer to as, beer belly and all that. And so in children and adults, they can both have issues with urination because of blockage or congenital issues that arises that causes a physical blockage of the urethra. And the urethra is divided up into 5 separate locations. And I won't go too much into that because that has more to do with technicalities, like for surgery. And so this patient ended up having his injury is where the bulbar area is. So the bulbar is just one section of the urethra, and from an unknown cause. Typically, things that can cause scarring in the urethra would be like STDs, like gonorrhea. That's why it's important to have protected sex and stuff like that, because if you get a gonorrhea infection, it can lead to scarring of the urethra requiring surgery. You can have tuberculosis is rare, but you can have tuberculosis, balls that can clog up the urethra. Stone is another one. In men, prostate is a big issue that causes compression of the urethra. And the issue when you have compression is that it can since the urine can't go this way. Let's pick a different color. Why don't we just pick red here? So let's just say you have an obstruction here. Well, if urine can't pass through there, then what it is the urine is going to accumulate in the bladder. And the bladder can only hold so much, right? And so above H2, there's a calculation that I kind of use to kind of calculate kind of the average bladder volume, which is really just age plus 2 times 30 equals X milliliters or cc. So for instance, if you're 10 years old, then you add 2, plus 2, not plus 20. Or let's say you're 10 years old or 8 years old, then you add 2, and that gives you 10. And then you multiply by 30. So in a 10-year-old, their bladder capacity, the average bladder capacity should be around 300 cc. Now, it's not super accurate, but it's good enough to at least get a general sense, because to really get a true bladder volume, you really have to infuse the bladder with contrast or dye and then take an x-ray, and then you'll know what true bladder capacity is. But for the most part, with patients that don't really have neurologic issues that can affect their bladder, this formula works good enough. But so the issue here is when urine gets made from the kidney kind of filters the blood, and the waste is the urine. Then the urine comes down here. Well, if the urine can't go past this little area, what's going to happen is it's going to cause back pressure. So it's going to cause the bladder to fill up. And the bladder is a muscular organ. And so when you have long-term obstruction, what's going to happen is the bladder will undergo changes, such as collagen deposition and stuff like that, and you'll reach a point of no return. I was going to bring some pictures for you to see like what a damaged bladder looks like, but I forgot to bring it. So maybe on another episode, I'll show you guys how a damaged bladder looks like. But over time, if the bladder is constantly working hard, just like the heart, if it's constantly working hard, it's going to become thickened. And when it becomes thickened, it's not going to contract the way it's supposed to. And so then now what's going to happen is the pressure from the bladder now is going to go back up to the kidney. And then ultimately, the back pressure from the kidney is going to injure the kidney. And then that kidney can die, basically. And so that's why if you can't void through here, then, you need to somehow get that obstruction out. Now, I won't go into ways of temporizing it until you can find a surgeon that can fix this type of defect, because it's not easy. Now, just from what I know, I'm actually the only surgeon in Houston that actually operates on adults and kids' genitalia. So any urethral issues, whatever it may be, my two partners don't really do complex stuff like this. And so I'm the only one that kind of, at Crescent Urology Institute, I'm the only one that kind of does all of these complex penile repair or, urethral repair, stuff like that. And so in this patient, I told him, I said, he has no history of like sexually transmitted disease. So most likely he never had trauma there. He just didn't have anything. But, up to 50% of patients, either they don't remember or there really is no identifiable causes. But the good news is you treat them the same anyways, because the stricture, the initial management is actually seeing if you can go in under anesthesia, of course, go in with a camera, and then the camera has an accessory to it that has a blade, or you can use laser. There's multiple ways of doing it, but the whole point is, when this is me looking into the urethra, okay? So, like if this is the urethra, this part right here. So the red part is some sort of scarring that's developed here, and it's preventing urine from, well, let's use yellow for urine here, from going past this. And so in this patient, we don't really understand, or there was no identifiable cause. So his initial treatment, which was the correct treatment, was they went in with a camera, and basically what they did was they used a knife that you can insert into a special camera, and what that does is it cuts. You really don't want to cut up and down just for technical issues, and you really don't want to cut too down, because that's also where the rectum is, and you can get into complications with that. And so normally I like to just cut at 3 and 9, and then maybe sometimes a little bit at 12. And for instruments to cut it, there's so many you can use. Some people like laser, some people like cold knife, some people like hot knife, some people like a hook. It doesn't matter. The whole point is you cut the scar out. And so this patient got the scar cut out and did fine for years, but then it came back. But this time, there wasn't really anything to cut. It was just a narrowed area of about 2 centimeters or so. So what I actually had to do was so basically you have to kind of do it in a special position. So like if this is his scrotum right here, and then this is kind of the what we call the perineal area, and then this is the rectum, and then this is the legs, and then the body's up here. Okay, and so to get to this part, basically I had to make an incision right here, and then once you do that, you can actually get to where this is, and then you can feel it and you can see it too, because you'll see a tube that's straight and then suddenly it narrows like an hourglass. So if you're able to look at the defect, it'll look something like this. It's like an hourglass. And then so this is the part, well, let's make it kind of even here. Okay. And so the part you need to cut out, that I need to cut out, is going to be this and then this, and then you reconnect it. Okay, so that's really the only durable way. And it's an outpatient surgery. And so in this patient, now it just depends on how long the scar is. And everyone's anatomy is a little bit different. And so what I do is I kind of, once I cut out the scar, I kind of tug on it, or I open it in the front first before I actually cut it, just so that I can see, can he do a primary anastomosis, meaning can I just cut that out and then just sew this part and this part together and then just cut that out? Or do I need to do like an onlay, which means I take tissue from the mouth, because it's similar to urethra, and then I can use that as replacement tissue. Well, this gentleman was lucky enough where I didn't have to do that. So what I did was I just cut the scarred tissue out, and it was still loose enough that I was able to basically, once the scar is cut out, then it looks like this now. And then, I put sutures all around. And so there's really no magic to the surgery. What makes it hard is that it's just the dissection, the bleeding, visualization, stuff like that. And so, but, he was young, and so, when we put a camera in him in the clinic, initially, a few years ago, you could see that his prostate wasn't that big. And then basically, physical exam and imaging really didn't show a prostate that probably is what's causing this. And you can obviously see it in clinic with the camera. And so, of course, in the OR, I confirm it first too. And then, I cut that out, and then, and so he's doing well right now. I don't know what this is, so let's get rid of that. Yeah, I'm not sure what this is, but we'll get rid of all that. And so that's kind of how a urethral stricture is corrected. And then the symptoms you would find would be, you would have a hard time urinating. You have to squeeze to urinate, and the stream will be thin. But keep in mind that urethral stricture is probably not going to be your number one cause. You kind of have to look at the age group, right? So if they're young kids, then first thing you want to look at is the opening of the meatus or the penis. Is it tight? Is it scarred? Because if it is, then, you know, what I do is I order what I call a pre and post void ultrasound, where it just shows how much is in the bladder before urination and then how much is in the bladder after urination. If they're able to empty their bladder completely or almost completely, and what is almost completely, we don't really have a definition for what that is. Is it 1/3 of the bladder capacity? Is it 1/4 of the bladder capacity? And so I kind of just use, if you're able to empty about 1/5 of your bladder capacity, then I consider that, you know, you're probably able to empty it until definitive management can take place. And so, but if you're, let's say you're only able to empty 30%, well then that's pretty significant. And also the ultrasound will show me if the ureters and the kidneys are dilated, because if they are, then that, you know, and then you also see a thickened bladder. Now we don't really have a definition what exactly is a thickened bladder, right? Is it 1 centimeter, 2 centimeter? But it's one of those things where if you see it, you'll know it, but it's hard to describe it. And so, you know, if I see symptoms like that in children and I see an obvious tiny hole at where you urinate up, well, that's an easy problem to fix. Just open up that hole, cut out the scar, put a few stitches in, and then that's it. And then for the adult group, kind of like the sexually active group, then you have to look at, is it posterior urethral valves that was delayed? And posterior urethral valves is basically just the urethra. Let me see, I'm bringing the whiteboard back up here. And so so depending on the age group, you know, it just depends on what the age group will kind of determine kind of what's causing the stricture. Because children tend not to be sexually active and all that, and they tend not to have trauma there. And so for children, it's usually a congenital issue. And one other thing is posterior urethral valves. And that's just basically tissue. I don't know why this keeps popping up. Posterior urethral valves. Okay, so that's in children. And that's just basically kind of, if you cut the urethra in half, it's just like a drape of tissue. And so with those, it's fairly easy to treat. You kind of just cut the tissue, leave a catheter in for a few days, take it out, and then usually they do fine. In the kind of older children, then it could be a delayed finding of posterior urethral valves, meaning that it just wasn't as bad initially, and then now it just became bad. But typically, posterior urethral valves will be found in utero, because what it's going to do is exactly what I talked about earlier, where it's going to cause back pressure to the ureter and the kidney. So on the prenatal ultrasound that pregnant people get, you're going to see a dilation of the ureter and the kidney. And I won't go into, like, you know, how you manage those, because it's still a little bit of uncharted territory in a sense of, you know, trying to shunt and do all this. But in older kids, then, and, you know, the test you order, there's a test that you can order called retrograde urethrogram, where the radiologist just kind of put dye and then lights up the urethra to see if there's any narrowing. And then kind of in the sexually active 20, 30-year-old group, you have to consider, trauma, like, do they stick, there are guys that like to stick things up the urethra because it makes them feel good. And then that can cause scar tissue, or it could be due to frequent catheterization from inability to urinate because of spinal issues, or inability to urinate because of scarring secondary to having multiple catheters placed for multiple surgeries or whatnot. But you also have to make sure they're not, they never had like gonorrhea or something like that, because that can also cause scarring. And then once you reach kind of the late 40s group, you got to start thinking about prostate, which obviously can compress the urethra. But I won't get too much into management of that, because there's a lot of ways to manage an enlarged prostate. That's really a topic for another day. Let me see if I can get one of my partners who kind of specializes in that to come talk about that. But so that's pretty much it on urethral blockage. So if you ever have a hard time urinating and you feel like you're having to squeeze and all that, don't ignore that symptom, because that could be due to there's some sort of blockage. And I would definitely see your primary care doctor, and most likely your primary care doctor will, do the initial workup. Is it urinary tract infection? Is it, this, that? And then basically most likely they will refer you to a urologist, who would then do kind of further testing to kind of see what's going on. So I hope that was helpful in patients who have difficult time with urination without a known cause. And these usually happen gradually. So rarely is it you wake up one day and then you just can't urinate, And then another common thing that people get concerned about is they see something called a double stream. So when you urinate, you're really only supposed to see one stream, right? But sometimes you see a double stream initially, and then after a couple of seconds, then that double stream becomes one stream. So that most of the time is actually just a normal phenomenon. The urethra does compress, and so if the force is not strong enough initially, then you're going to get splitting of the stream, and then as the bladder pressure generates more, then it'll become one stream. And so that may or may not be due to any of this, and it may just be a normal phenomenon. So if you see two urinary stream but you never had surgery there, and you don't feel like you're having to squeeze or anything like that, I would still get it checked out, but most likely it's probably a normal phenomenon, and you probably don't really need any sort of treatment. And so, but that's kind of that's pretty much kind of it on how you fix urethra or urethral injury. And I've done a few high-profile cases that that's been published on the news, and so some of these can be very tough, because especially the ones that are caused by trauma. And what I mean by that is they have a car accident, and then let's just draw this back for a second. So the rule of thumb is the closer the injury is to the bladder, the harder the surgery is going to be. Because right here is also your pubic bone. And so one of the hardest one is, but thank goodness it's rare, but in motor vehicle accidents, when you fracture, the pelvic bone or whatnot, that piece of bone can actually fracture the bladder, or, injure the bladder, or it can actually fracture the urethra. And those can be very tough to fix, just because you don't know how much scarring there is, and just access to it. And so that's why these really should be done in centers that do a lot of these, because this is a no joke surgery. And then the further the scarring is, then the easier the surgery is. And then, like I said, if your scarring is too long, then you can always use either your labial tissue, which is tissue right here, or your buccal tissue. And the reason why we use it is because it's durable. It has a lot of science to back it up. It regenerates, so you can use unlimited. This just brings, I kind of go on a side a little bit, but I remember we did a surgery once on a patient that had multiple kidney surgery. And because she had multiple kidney surgery, her ureter, it was almost a five centimeter defect. And 5 centimeter in medical length is very long. So basically she was young. And so one option is take out the kidney, which we didn't want to do because she was young and that kidney was healthy. A second option is you can use a piece of bowel and construct it so that it can serve as kind of once you cut this out, then you put the bowel. I'll use red for, once you cut this out, you can use a piece of bowel, and there's a way to fold it and interpose it here. The downside to bowel is that complications from any bowel surgery, you're looking at around 50%, whether it be ileus, adhesions, whatever it may be. But bowel also makes mucus, and so, you run the chance of clogging the ureter, all that. And so another option is to, if the ureter is long enough, you can reroute this ureter, this part. Once you cut out the scar, you can try to reroute it from there to connect it to here. But still, that requires you got to have some sort of ureter. Now, I won't go into too much on how, you can also use part of the bladder to be a replacement of the ureter. But like I said, I just don't find good successes with that. What I do find good success with is actually tissue from the mouth. So what we did was we were fixing it robotically. So my partner was fixing it. And what I did was I harvested a 5 centimeter piece of mouth tissue. And it's like 5 by 4 centimeters, something like that. And then basically what he did was he just took that piece of tissue and kind of rolled it into a tube, and then he connected it to this right here. And a year out, she's doing great. No obstruction. We did tests to see everything's flowing through. And then the blood supply that is going to supply that is pretty much just by a process called imbibition. And what that means is that there's no blood, it's not like a flap where you have a vascular pedicle or a vascular supply that goes with it. This is what you call a free flap, if you will, where basically the vascularization is going to come from the psoas muscle and the tissue around there. So what you do is you really want to compress that tissue onto another tissue that's vascular, and then that tissue that's vascular, like the psoas muscle or whatever, will vascularize that area. And So whether that fails or not fail all depends on the process of the vascularization, because like with anything, if you don't have vascularization, then that's not going to survive. And so in this case, of course, it did, and so she did great. And so that's just amazing, like kind of how far science can go in terms of using the mouth tissue, because literally I use the mouth tissue for pretty much any major reconstruction that I just don't have original tissue to work with the exception of skin, because skin is a little bit different, but we won't talk about that in this episode. But skin can be, when I fix botch penises or genitalia and I don't have enough skin, it's gonna be very tough. I can tell you that. And so, but we'll leave that topic for another day. And so I hope you guys enjoyed this episode on kind of how I kind of repair urethral stricture, or and it can be from car accidents where the bone actually cuts the urethra. It could be from a gunshot wound that cuts, gets shot in the penis and cut through the urethra. It could be a stab wound where, somebody cut off somebody's penis. And I put those back together before. So believe it or not, it's just sensationalized with Lorena Bobbitt and stuff. But that surgery really is not that hard. The hardest surgery I would have to say in my lifetime is transgender surgery. That is very difficult. And so for me, I just think, I'll fix it in children that are born with congenital issues. I wanted to bring a patient on. It's just we couldn't find timing. But it's a very interesting case. But I'm going to try to get the patient on here just since transgender and all that's a really hot topic right now. But briefly, I'll tell you. So this child had a very rare chromosomal disorder. The child actually has XX chromosome. So it's a girl, right? There's no mosaicism, so there's no like XXXY. And they go through this intense, meeting with all these other doctors, endocrinologists and all that. I'm just a plumber. Like, at the end of the day, I don't really have much opinions on that, because that's really outside of my realm of specialty from a psychiatric standpoint and all that. And so the parents decided that, since he had no internal organs such as uterus, ovaries, testicle, nothing. And it's funny because even the translator didn't even know how to translate it. So that's how crazy it was. And so the clitoris and the penis are from the same origin. And so, but, there's something called imprinting. And so prior to doing the surgery, we have to tell the parents, listen, what I'm fixing on the outside is called the phenotype. But on the inside called the genotype, which is the chromosome being XX. There's something called imprinting that we don't really fully understand the implications of that. And what I mean by that is, if you're born a girl, are you going to have girl tendency like when you grow up? And so I don't think anyone has any good answers to that yet, because this is really, transgender really is a new topic that there's a lot of political implications, a lot of religious implications, a lot of social implications. And so I I kind of stay away from kind of amputating the penis and all that because I just don't know enough about the ramifications down the road in terms of like, you know, how these patients will be. And so until we have better facts, I just don't, I don't want to kind of get involved with that. However, if a child is born with, like this child, with chromosomal abnormalities, well then, you know, then that, and even then, you know, what is the right answer? Should you wait until they reach a certain age so that they can make their own decision? Or should the parents make the decision for them? I don't know. I really don't have an answer to that. You know, and so that's why I'm so glad I'm just a plumber, meaning that, you know, I just fix or create what the parents and the entire medical team have a consensus on. And keep in mind that it also varies from region to region, right? And so if this child was born, I don't know, maybe in California, then the team over there, they may have a different thought. If the child was born in Oklahoma, then the team over there may have a different thought. And so there's just no right or wrong answer to this. And that's what makes it frustrating and hard. And so that's why, you know, but imprinting is real. And imprinting just means that if you're an XX chromosome, you will potentially have female, what would be the right word I'm looking for? Tendency. And so this child, and looks, and so this child, the parents decided to raise as a boy. And so I can't remember, it took me probably a good 2 or 3 years to, you know, because you got to give them testosterone, and I got to use mouth tissue to make the urethra. It's complicated. But you know, the clitoris and the penis have the same origin. So I was able to turn it into a penis. Like if you looked at it, you wouldn't even know that, like it looks like a regular looking penis. And, you know, so unlike adults where if you amputate the penis, plastic surgery, you usually have to use like a forearm muscle and skin grafted, and then they put a penile pump in there, and it just never looks good when you're trying to create a penis. And so and it's irreversible, obviously, you know. And so, but in this child, I had already, you know, before surgery, I always have to tell parents everything. And I told these parents, listen, you know, I'm not going to give my opinion too much on what I think the baby should be raised as, or should the child be up to a certain age, and then let the child decide as an adult or whatnot. But culturally, they wanted to raise as a boy. Raise him as a boy. And so I fixed it, and I wanted to bring them on the show. Just there's a scheduling conflict because that is a very rare disease. But my point with that is amputation of the penis and then putting it back together, that's not hard. You know, you know, I did that, you know, and I think I talked about that in one of my podcasts years ago. There was, I think it was all over the news. There was a patient that, you know, the mom, I don't know what, I can't remember now. Did she have like postpartum depression or something like that? I don't remember. But if you Google the news, it'll be there. And basically, the mom, you know, cut his penis off aside from stabbing him. And I'll never forget that day because I was on my way out with my PA, and I was exhausted that day. I don't know how many penis surgery I did that day, but I got a page. Yeah, I know. Can you believe it? We still use pagers in the hospital. I don't think they do now. I think it's pretty much all transitioned to cell phone now. But back in the day, it was a pager. So I'll never forget. It was at a major hospital, and basically I got paged, and I always joke around with the OR staff. So we always trick each other, not like harmful tricks, but playful tricks. And so I got a call that asked me to come back into the OR, OR X, I can't remember which OR it was now, but it was a trauma OR. And when they took the baby to the hospital, and I think the child was around 2 at the time. It's been a while. But it happened in Houston. But like I said, if you just Google, mom amputates penis or something, you'll probably find the story on there. And basically, whatever tissue that they find on the ground, I think they just kind of put it in ice because you never know. It could be a finger or something like that. And so the child was stabilized, so meaning that his condition was good. And so the penis, when you kind of amputate it, believe it or not, it can clot itself off, so you won't even know that. Especially in an emergency situation where you have like 20 people in the OR, you're not gonna really see the penis. And so somebody placed a catheter in him and didn't notice that half the penis was missing. It wasn't until the charge nurse, who doesn't work there anymore, looked in the trash can in the OR, and she saw literally half of a penis. And so they paged me to come back, and I was exhausted that day because I'll never forget it. I was walking out with my PA who assists me with surgery, and I do so many surgery that my neck always hurts. So that's why I don't overdo, like the most I'll do is 8 surgeries a day. And I don't mix complicated surgeries with simple surgeries. And so I remember that day, it was around 5 or something, and I was walking out. Then I get paged, and then I called that number back, and they said, Dr. Pham, you're needed in OR. I don't remember the OR. Let's just call it ORX. Dr. Pham, you're needed in ORX. So I said, what for? Because sometimes, it could be like, oh, we can't place a catheter, but really all they have to do is push the catheter a little bit more, or it could be something that I really don't need to be there. I can just tell them what they need to do. And so they said, I think half of the penis is cut off. And I was like, what? And I was like, whoa, hold up. I'm like, okay, guys, I know I'm a fun character, but I'm exhausted. This is not the time for jokes. And whoever was on the phone was like, no, Dr. Pham, this is not a joke. And so I know the charge nurse, and she doesn't joke. So I said, well, can you put the charge nurse on the phone? And so I talked to the charge nurse, and the charge nurse told me, no, Dr. Pham, this is for real. We think there's a penis in the trash can. And I was like, what? I was like, okay. And I haven't left the hospital premise yet. I was walking towards the parking garage. So then I told my PA, okay, we need to go back. And the PA, I'll never forget it. She asked me, she's like, and remember, she was fresh out of PA school. She had only been with me, I think, a couple months or something like that. So she's a newbie. So she asked me, what's going on? I said, I don't know. They said like some penis got cut off. It's in the trash can. And the look on her face was just priceless. She was like, what, what? And I said, I know. I said, I know. I said, let's just go back and let's see what's going on. So I went back into the OR, and I kid you not, there was probably about 6 people just staring at it. And it had been less than 6 hours. We just guesstimate. But it, and then since they put it in ice, maybe you get a little bit longer. But for some reason, somebody accidentally threw it in the trash can. And because the child's penis had already tamponaded or clotted off, so, you don't see like this gushing of blood. And so I basically looked at it and I said, yeah, that's a penis. And so I took betadine and just kind of really cleaned it up. And then I, under magnification, I kind of re-anastomosed it. And then the child actually is doing fine. The penis looks normal. And I can't remember. I think mom got like 99 years in jail or something like that. I kind of I never followed up on the story. But I'll just remember from that day on, I think that's when one of the nurses, and I can't remember who, gave me the name Penis King. And, just like with anything, too much of anything is not good. So once, I remember the next day the CEO came up to me and he said, hey, I heard what you did. He's like, that's really amazing. He said, thank you. And I said, oh, I just said, I'm just doing my job, And so from that day on, a lot of private OBs were having me do nursery circumcisions. And so literally for years, it's got to be for at least 5 years, where I was doing 80 to 100 nursery circumcisions a month. And the way the nursery circumcisions do it is there's a few ways of doing it. One is a plastibell, and the plastibell is basically you just put a plastic piece kind of on the head of the penis, and then you pull the skin over, and then there's a string that you just kind of tighten it. So what you're doing is you're strangulating the penis skin, and then after about 7 to 10 days or so, then the penis skin will fall off. And then, but sometimes it can get stuck or whatnot. And but it is, to me, the safest, because you're probably not going to run into bleeding or anything like that. If anything, the worst thing that probably can come from it is, unless you have an underlying penis problem, and then that I need skin to reconstruct, and then you end up circumcising the child. But let's just assume the child had no penile issues, then plastibell, I would say, would be the safest for physicians who wants to do circumcision but don't, are nervous about putting a stitch in when there's bleeding and stuff. And then you have to keep in mind, when you circumcise these babies, they're only like 1 day old, 2 day old, so they don't have a lot of blood reserve like an adult, where you can lose 200-300 milliliter of blood and still not need a transfusion, versus in a child, in a little baby like that, 6-7 pounds. I mean, there's you can actually get transfusion because of blood loss from a circumcision. So you cannot take circumcisions lightly. The second way of doing it, and you can use the plastibell. I've never personally do that, but I've heard there's clinics here in Houston that do circumcision in males using that method or something similar to it, where what they do is they just strangulate the skin and then let the skin fall off. I just never been a big fan of it, because you kind of have to wait for it to fall off, and I just don't think the cosmetic looks that great. But it is safe. And so, if you're at a place where you really don't have some sort of pediatric surgeon, or at least a urologist who or a general surgeon or whoever that's comfortable putting in a little stitch to stop the bleeding, then I would say Plastibell is good for that. The other way of doing it is the Mogan clamp, which I call it like a cigar cutter. And so that one I don't like to use because you run the risk of you literally just cutting the skin, and you can run the risk of, and I've seen it happen where you can accidentally cut the head of the penis in half. And with that, like you really need, if that happens, that baby needs to go back to the OR stat, and then you can try to sew it back, And so thank God I've never encountered that from someone else. So the one I like to use is GOMCO, GOMCO. And that's just a device that is has like a metal bell that you place on the head of the penis. Then you pull the skin over. And then what it does is it clamps the skin together. And if you want to know more about it, if you go on crescenturologyinstitute.com, there's a video on how to care for circumcision after circumcision. And it actually shows you what the GOMCO is and stuff. But the GOMCO, you kind of have to have some strength, because it requires, you have to actually twist this thing to clamp the skin together. Because if you don't clamp the skin together, that's how you get bleeding, is because you don't use sutures or anything like that when you use the GOMCO. But I literally developed arthritis in my thumb because, I'm literally doing this. And just imagine 80 to 100 a month. So there would be days where, I did 6 surgeries, and then there's like 14 babies waiting to get circumcised so they can be discharged. And I mean, I don't even know how I was able to do that. I mean, I was working 16 hours a day, like every day. I mean, it was just rough. And so finally, I want to say after about 4 or 5 years, like I wasn't going to jeopardize my hands. And to this day, I still kind of like have a little bit of arthritis or something, because if I don't massage out my fingers like this, it kind of gets rigid. And so that's why I only do circumcision in the office if they need it. But fortunately for me, I have to say 99% of patients that come to me is because they have a penis disorder, and not because they're there because they want a circumcision. But anyways, I kind of sidetracked a little bit, but I think circumcision was something that I think I had a separate episode on it, but my point is, transgender surgery is actually very hard, and probably is, if I have to say 1 through 10, I would put transgender surgery at around 9, because if I haven't met a 10 yet, and trust me, I meet a lot of crazy cases, and so because once I meet a 10, then I'm going to call it a day. Then it means I've seen everything. And so I would say amputation, putting the amputated penis back together, is probably a 5. And the main thing you worry about is just venous congestion. But, they have leeches and stuff that you can actually put on the penis itself to kind of suck that blood away. So that you don't end up with congestion, which can then lead to failure and stuff like that. So, but let me, hopefully I can bring that family on. They've been wanting to come on. It's just such a schedule conflict, because the times that they're available, I'm not. And so, but it's just, and then the imprinting thing, like, as I had already told parents, and so want to say 7 now, whatnot. But yeah, they always have to keep his head shaved because if he even grows out a little bit of hair, he literally looks more like a female feature. And he likes to play with dolls and stuff, and not, what you would think, like, I'm not saying that girls can't play with trucks and boys can't play with dolls, but literally he's only inclined to like girl stuff. Like he likes makeup and stuff like that. And I think that's why for me, transgender surgery is just such a new thing, even though transgender surgery has been performed for many decades, but it's only recent that we're starting to scratch the surface on the psychological aspect of it, meaning the patient. If they're XX, then I do believe that they're gonna have female tendency. Now, to what effect, I don't know, and I don't think anyone knows. And it's just not common enough where you can really have really good data on it. And then plus, it's been so politicized that it just becomes very tough to really even get data, just because of the way the topic is so politicized. It's not like a circumcision where it's not political, and and we have a lot of data on that. And so, but that's just kind of to give you a gauge of kind of how complex transgender surgery is, not just the technical aspect but also the psychological aspect. And so I hope today's episode, the main driving point home here today is, if you, female or male, if you have any, I hope you guys learned something from this. So if you guys have any symptoms that involves having the strain, or your child having the strain and all that, don't wait too long to get help, because once the bladder undergoes what you call tertiary changes, it's irreversible. And so I'll leave you with this one final story, because mainly I've been talking about males, but this can occur in female. So there was a patient that basically had childbirth in another country. And she, I guess during delivery, you can compromise the blood supply to the urethra, just from the baby's head pressing on it. And mind you, this is just the story I got from her. I can't request records from the hospital from that country. And so for 10 years, she has been, or probably even longer than that, she's been having trouble urinating, and she's seen so many urologists, and all they ever do is just dilate it. They dilate it for her, and then she would be fine for a week or two, and then she would come back in, and they would dilate it for her. And so even though she would get dilation, just having to go get it dilated every 2 to 3 weeks, I've never had it done, but I can tell you it's probably not comfortable, because when we put cameras in female urethra in the clinic so that we can, now this is in adults, you can't do this in children. They're not going to lay there for you to put a camera in there. And plus, they don't make cameras that small that we can do it in clinic for children. But basically, when we do the camera, it's just uncomfortable. Just imagine if, and for people who've had catheter, how uncomfortable that can be. So for 10 years or so, that's what she kept doing. And I don't know why the urologist kept doing that. And so then she basically asked the insurance agent, like, hey, do you know anybody that can help me with this? Because, I'm having to self-catheterize when I can't make it to get it dilated, and I keep getting infection because, if you can't empty, you'll have stagnant urine, and there's bacteria all around us, and then especially in female, the urethra is short, so they can actually just, if you don't kind of hydrate and urinate everything out, the bacteria can eventually go up to your kidney and can hurt your, can basically kill off a kidney. And so if it's contained in the bladder, you'll have these symptoms. And for those who have urinary tract infection, you know what these symptoms are. They're just not fun. So then, basically the urologist she was seeing was like, I don't know what else I can offer. And so she was pretty much, she just didn't know where to look anymore. She told me all she did was just prayed and, just hope for the best. And she wasn't that old. She's like in her early 40s or something. And so she asked the insurance agent who help her, buy insurance or whatnot. She was asking her, like, hey, do you know of any urologist that can help me with this? Because this has been an ongoing issue and I just can't keep living like this. And so the insurance agent said, there's a guy by the name of Dr. Dung Pham that, he likes to tackle these kind of complicated cases. And so she's like, and then so the patient, because I asked the patient how she found me. And so the patient, but the insurance agent said that, I've had a lot of patients that they ask specifically, hey, what insurance Dr. Pham or Crescent Urology takes, because, my partners too, is not just me. And so she said, well, there is a guy that, he mainly does pediatric, but that's because, I have 2 adult partners. And so, we kind of specialize at Crescent Urology Institute. But when it comes to general reconstruction, then I kind of do adults and kids. But I really don't really promote the adult side just because I'm already super busy with just children alone. And so she said, but I've never met him. I just heard, he likes these type of cases. So then that's when she got evaluated by my partner, because when you call the clinic and if you don't specifically ask for me, then by default, if you're 18 or above, then the assumption is you're going to go see an adult urologist. And so my partner saw her and basically did the workup and everything, and her bladder has already undergone some changes, but not permanent damage yet. And so he asked me, we meet once or twice a month to go over like complicated cases and what all the partners think we should do. And so we talked about her case. And so I said, well, I don't understand why people keep dilating it when, that's the definition of insanity, right? Doing the same thing over and over, hoping to get a different result. And so I told my partners, I said, what she needs is to cut, she has an obvious scar on the urethra. And so, like, this is her urethra, she has an obvious scar like this. And that scar is just not mobile. And so when you dilate it, all you're actually doing is cracking that scar a little bit, but then it's just it's just going to come back. And so I said, to really fix it, what y'all need to do is cut this scar out. But you can't just cut the scar out and then just fold the urethra back, because now you can make her hole tiny like this. And so I said, what she really needs is a procedure where you cut out the scar and then use tissue from the mouth as replacement here, so that, basically when you're done, what her urethra will look like is this. And the red will indicate the tissue from the mouth. And remember, the mouth tissue regenerates itself. So, and we did that. So while one of my partner was cutting out the scar, my other partner was just assisting me to harvest the tissue. And I can't remember, I think it was a 2 by 3 centimeter strip of tissue, something along that line. And then basically after that, then, after we harvested the tissue, then I defatted it and everything, then I gave it to my partner. And then what he did was he sewed it in, and then you remember there's no blood supply to it. So you got to kind of suture it down to, or tack it down to kind of the tissue around that area, and use the catheter as a kind of a compression device so that this piece of tissue can get vascularized. And this was about 6 or 7 months ago. And when I saw her back, basically, she literally just said that, oh my God, you guys are like miracle, like sent from above. And because now she's able to urinate with no pain. She never has to worry about catheterizing. And lucky for her, the bladder hadn't undergone changes that was irreversible. Now, there were portions of the bladder that was irreversible, but for the most part, she's able to urinate like normal without having to worry, and success rate in this is going to be pretty high, and because it's been probably now it's going to be been about a year now. And so she's doing great. And periodically we, because it's just such a rare case, periodically we would call just to make sure, she's doing fine and all that. And so my point is, strictures or scars in the urethra can occur in males or females. The pathology may be different, meaning what caused it may be different, but the treatment is very similar, and so, but anyway, so I hope you guys enjoyed today's episode, and I hope it, at least, for patients that may be going through these symptoms, and you're watching this video on YouTube or listening it to on a podcast, then I hope this may be able to help you at least get evaluated, because it may be that you have a scar and all you need is a simple treatment. So once again, thanks for tuning in to another episode of D-Talk with Dr. Pham, where we talk more than just urology. But since this was a topic that a patient requested, I do, just so that he can, fully understand the kind of the concept of the surgery and stuff. And, I just feel bad that I couldn't make the video before the surgery, but which is okay. I mean, I kind of explained everything to him, but he just likes to see it in a more detailed fashion like this. So well, it's been a pleasure. Thanks for tuning in, and remember, subscribe. Click the link below, And then always remember, never self-diagnose. If you feel like you have some of these symptoms, go to your healthcare professionals. And if a urologist is warranted, they will send you to one. Or if your insurance allow and you feel like you just want to see a urologist right away, you can do that too. All right. So this is Dr. Fam signing off.
Look, it's priceless. Take it to the moon. Priceless. One day will be soon. Look, it's priceless.